Welcome, everybody. It is a great pleasure to see you all around the world on various platforms to this, and I want to welcome you to this new initiative, which is a digital educational format called Heart-to-Heart Conversations. We felt that there are at least two needs that we would like to address with this new format. And the first was that to provide you with a brief and concise overview of a hot topic in interventional cardiology. And secondly, to make it possible for you to interact with thought leaders in the field of interventional cardiology. This being said, you can follow us and follow this conversation on various platforms, as I said, like X or Facebook or YouTube or PCR Online. But the only way that you can ask questions is to be on the PCR Online. So if you want to ask questions to my guest today, please do this on PCR Online. And my guest needs a lot of introduction when it comes to the first topic that we have. This is Jose Maria de la Torre Hernandez from Santander. Jose Maria, what is this nice image behind you?
This is my city. This is Santander. This is the twilight. The picture is the twilight. There's no twilight now, but it's a very nice coastal city in the north of Spain. As I was telling you before starting, Dejan is a very beautiful seaside in the north. Very nice.
Nice. Very nice to hear that. So as you could see on the introductory image, our topic today is Intracoronary Imaging Guidance for left main PCI. And you have been involved in this field for many years. You're one of the pioneers who pioneered and who provided evidence for this topic. So basically, my question to you, the first question will be, what do you think are there arguments for having a routine intracoronary imaging guidance for left main PCI? So that is the question for you.
Yes, it's a very big, important question, crucial question, because behind this is everything. Now, as you said before, I was starting my experience in left main PCI over 20 years ago, long time. And I was in 97. Then I started to apply. I was to the first procedures performed in my institution here in Santander, Hospital de Fisia. And I think in summary, I could say that I was imaging for left main disease is definitely helpful. It's helpful to evaluate left main disease and optimize the procedures of percutaneous vascularization. Why? Because we can evaluate the disease extension, how it's affected the osteal early, the osteal circ. Then we can guess if you need a strategy of 1 or 2 stents, which is very important. We can characterize the plaque and then to plan the plaque preparation. We can also proceed to the correct sizing of the stents, sizing of the balloons for pot. And then finally, we check out of the result of the stenting, just paying attention to expansion and position, etch the formation of the stent, or the presence in the stent edges of plaque or dissections. No? This is why I think it's important, because this is at the same time related with clinical events, with outcomes. No? The best result in the acute procedure is translated into a prognostic advantage for the patient. That's my main question for this. No.
So just to ask you a direct question, the question was, should it be routine? And all of the things that you outlined that you can see with intracoronary imaging are, of course, important.
Yeah.
But when you say something should be routine, like primary PCI and STEMI, that's a very strong statement.
Yes.
So my question to you, do you think that the time is ready where you, as a pioneer of intracoronary imaging, would state that if you perform left main PCI, it should routinely be guided by IVUS or OCT? Is the time ready for that?
I think it is, but you agree with me that there are other considerations, for example, the cost and the economy. No? I think some people would say, okay, I would like to do ideally imaging in all my cases, but it has certain constraints in my institution. Okay, then you have to be more selective. But if you push a little bit to your administration and convince that a procedure such important like left main PCI needs to be really optimized, and everything what happens at the level of the left main may have relevant prognostic consequences. At the same time, we are competing with surgery. We compete with surgery, particularly in patients that are in a very high surgical risk. And then if they have very good results, we have also to provide very good results not just in the acute phase, but also in the long term, in the years following. If we start to see a high rate of restenosis, of even MI in the follow-up, then we are going to be in trouble. Then for me, routine should be the target, should be the goal, to do it routinely in all the main cases. But I understand that sometimes in certain circumstances, maybe it's not feasible.
Yeah, I agree with what you said. And there is an important thing that you mentioned. So there were trials investigating left main PCI. Left main PCI against surgery,
Yep.
like Noble or Excel recently, or different techniques like provisional versus two stents,
Yes.
like the DK Crush trial or the EBC main. However, the utilization of intracoronary imaging in all those trials was at best modest. Even in the dedicated technique trials like EBC main and DK Crush, there was, if I'm not mistaken, not more than 40% of patients treated with IVUS guidance or OCT guidance. Do you think this plays into how we perceive these studies? And do you think that using intracoronary imaging guidance could have delivered different results?
You're totally right. If you see the analysis of the Excel trial, for example, or Nobel trial, and you look for the IVUS subgroups that were, as you say, a minority, unfortunately, there was a better outcome in this group of patients. And also within these groups, those with the larger minimum stent areas, those with the most optimized procedures have better outcomes. Then it's clear there is a gradient of benefit from the just angio-guided to IVUS guided, and finally to the IVUS guidance with optimization achieved. And this is clear. That's why I think this should not happen again, to have such a low rate of imaging in the left main. I don't know if we're going to see many PCI cabbage trials in left main, because we did a lot, we had the guidelines, but maybe we see more, Dejan, everything is going. But if we do a trial like this, I think PCI should be with mandatory imaging, intravascular imaging, just to compete with surgery in the best condition. Yeah.
Okay, so let me ask you then another question, because you're a strong advocate of intracoronary imaging guidance for left main PCI. I would like to ask you the following question. Your argument for is based on which evidence? Observational or randomized so far? I mean, if we look at the evidence base, at least the way I understand it, and I would like to hear your opinion.
Yeah.
So far, we have had mostly observational data, and with IVUS.
Yeah.
And if we look at three landmark observational studies, for me at least, starting as early as 2009 from Asia, Main Compare showed in a registry with matched pairs that IVUS would reduce mortality. Then your study in 2014, and 10 years previously, I said I already was reading your papers.
Yeah.
So it's a privilege to be talking with you today after 10 years. But then 2014 study of yours, where you pulled 4 centers from Spain, again, observational matched pairs, you again showed reduction in mortality if left main PCI is guided by IVUS. And then we have a very recent evidence from the UK, England and Wales, actually, their national database with more than 11,000 patients showing again a reduction if left main PCI is guided by IVUS or OCT. OCT picked up from 2014 to 2012 to 2014 in the database, up to, let's say, mostly 10%, but 90% were done with IVUS in the database as well. So my question to you, those all are strong data in terms of mortality reduction. They all confirm mortality reduction, which is a big thing. However, they're all observational. So how do you comment that? Can we say that a technique should be routine based on observational data?
Totally, it's exactly the point, Dejan, as you say. We have just very small trials from China in 2015 and 2019, but very small. One was 61 versus 61 patients, the other 160 versus 160, and with not consistent results, because in the first there was a difference mainly in TLR, in the second was a difference in cardiac death, and no in the other. But there was some contradiction between these small trials. But there are many observational. You made a very good selection. These 3 are maybe the key registries, but there are others, maybe 10 or so. And all of them, most of them, I think I have the data that out of these 10 observationals, 8 were positive for IVUS in the long term. But even with large numbers, no, I remember when I designed my study in 2014 is because the main comparator analysis was relatively small and they were only analyzing overall all-cause death. And the findings were a bit intriguing because the difference was starting beyond the second, third year, which was a bit weird, no? Then we did an analysis of a larger sample, 505 matched pairs from full registries in Spain. We found differences in cardiac death, in thrombosis, in the combined of cardiac death, MI and TLR. Then make no sense. We identified a greater benefit in distal and main compared to other locations, and even more in distal and main with two stents compared to single stent. And finally, the UK people with a very big, large database showing an advantage in mortality, in survival for IBUS, and also showing that this benefit was greater with the higher experience of the operators, which this is very important. This means that IBUS is also relevant and pertinent when you are an expert in doing revascularization. The question is finally that we need a trial, and we did the trial, which is the optimal trial. The trial is optimal. I have the opportunity to join the initiators that look at Esta and Adrian Banning. And the trial was conducted by ECRI and Cardialysis, and we finished the enrollment last summer, 1 year back. We are in the follow-up. The primary endpoint is 2 years, combination of the death, MI, stroke, and revascularization. We will see. 3 countries, Spain, UK, and Italy, 30 sites, and it's going to be a very important piece of evidence. I think it's going to be positive. I don't know, but it's going to give us the last word, no? I think.
So there was a nice overview, and I think this is important for our viewers. This is one of the essences of the heart-to-heart conversations. We described the evidence base here. The evidence base is observational data dominate the evidence, and we have 2 randomized trials. You've mentioned some randomized trials from China, which are very small, but we have 2 large randomized trials now with some results. The October trial, which was not a dedicated left main trial. It was a trial about bifurcations, both non-left main and left main. And then the optimal trial, which is a dedicated left main trials, IVUS versus angio guidance. I would first like to ask about your opinion about the October trial. So this was a trial that included 1,200 patients roughly with bifurcations, with actually true bifurcations, who were treated in a way that they were randomized to angio guidance versus OCT guidance, and roughly 20% of them were left main. The trial was positive, so a combined endpoint consisting of ischemic endpoints was in favor of OCT guidance in the overall population. How do you comment on these results from the standpoint of left main PCI?
Yes, totally. It's right. The percentage of left main was pretty, I don't know, really very high, but it was important, 20%, 19% exactly of left main in both geographic and imaging groups. It's important to know that the benefit in this group was similar to the overall, a hazard ratio of 0.7, 30% reduction in the primary endpoint. And it's important because it was an intention to treat analysis, but in the geographic group, nearly half of the left main were treated with IBUS because, I don't know, for ethical reasons, the investigators allowed the use, I don't know, of IBUS in the angiographic group when dealing with left main. And then I think the difference in favor of left main and imaging left main would be even greater if this permission would have not been operating, no? Because it's a lot. Half of the left mains in the angiographic group having IBUS to optimize. Then, if there is still a benefit in the intention to treat, analysis is important. And also, it's very remarkable that 18% of the OCT examination in the left main showed proximal deformation of the stent, which is very important, and abdominal wiring. Findings that were related with events. Then, October, which is a fantastic trial, also provides important insights and evidence for left main PCI guided by imaging.
Yeah, so I think it's very interesting that half of angio-guided patients were actually treated with IVUS guidance because the doctors, physicians felt compelled ethically to use it based on observational data. Observational data, I think that's very important. So there is one of the questions that we received from the audience directly addressing the issue of OCT versus IVUS for the left main. We said October trial was dominated or was designed to address the question of OCT guidance for bifurcations. In your optimal trial, where you're one of the PIs, that has completed the recruitment, but is still following patients up. So we expect to have the results, I hope, I don't know, you tell me, next year or year
Exactly,
after?
maybe ESC 25 next year at
ESC
the end of the
25,
summer.
okay.
Yeah, let's see.
But that is purely IVUS guided trial, right?
Yeah,
IVUS versus angio guidance. Okay.
IVUS.
So one question is whether there is a difference between IVUS and OCT for the left main. What do you think?
I think we published a manuscript 2 years ago. It was a joint venture between Spain and Italy. I worked with my colleague Bernardo Cortese, and we have a database of patients with angiography, with IVUS, with LCT, and we did a propensity score matching, and we collected 3 groups of 300 each patients each with LCT, IVUS, and angio, and we could see that really the benefit for OCT was equivalent or similar to that of IVUS, and both were better than angiography. This means that OCT can do the same work that IVUS is doing in the left main. Of course, distal left main, not ostial, which is impossible to use OCT for ostial left main lesions or mid shaft in cases of very big and large left mains. But for distal left main, if you have quality of imaging, OCT can provide a similar advantage compared to IVUS. It's more our registry. There is another. We have the Lemon by Nicolas Amabile, also Lemon study, also providing a very meticulous and rigorous analysis of how OCT can help to optimize the result in the left main. It's totally feasible.
Okay, so you would support both ways as better than angio based on the present data. Okay, tell us more about the optimal trial. So in the optimal trial, the IVUS guidance was standardized, or how did you go about to use IVUS in that very trial, in the optimal trial, which is basically the first large randomized trial addressing the issue we talk about today, and that is actually the intracoronary imaging guidance of left main PCI.
But we did the same that in October trial. In October trial, they provided a very clear protocol of timing, checks, measurements, target goals, etc. And we did the same for the optimal. We provided some recommendations and protocol guidelines. Baseline examination was not mandatory, but highly recommended. Post-stent was mandatory, of course, but we set some criteria for optimization regarding expansion of position, dissections at the edges, or residual plaque in the edge of the stent. Then we were very clear. Please pay attention to the different aspects and elements of the checklist, and just before closing the case and leaving the patient out of the cath lab, do the imaging and check everything: the distal edge, the proximal, the expansion, the position, everything. And specific criteria were provided for optimization. That's very important, because I used to say that the use of imaging in these cases is not like to touch the patient with a magic wand and, wow, I'm going to have a very good outcome because I touched this patient with my magic wand. No, imaging should be actionable. IVUS and LCT are conducted because we get information, and from this information, we do an action, which is post-dilatation, new stent, I don't know, any action, sometimes nothing because everything is perfect. But actionability is important. Yeah, definitely.
When you say that, I would like to share my experience. When starting in the last few years, I've started using actually IVUS and OCT regularly for left main PCI. And one of the things that I noticed, and you mentioned this, in the October trial, when performing bifurcation PCI, what happened in almost a fifth of cases, so 1 in 5, was that there was a stent distortion of the stent that was implanted in the main branch, most likely by the catheter or the balloons on the interaction with following the abluminal rewiring, for example, of the side branch. So what happens in the left main, often what can happen is that you distort the stent that you implant. And then what you can see on imaging is multiple layers of the one stent that you implanted. So if you implant one stent from the ostium of the left main into the LAD, and then you follow up with the IVUS, you should not see multiple struts of the stent. You should see only one layer of the struts. But if you see multiple layers of the metal, it means you distorted your stent. Now, what happened to me several times when performing left main PCI, for example, if the second stent is needed, and I want to perform the kissing balloon inflation after the first stent, my balloon would not go easily into the side branch. So I would think, why is that the case? And then on the imaging, I would see something like multiple layers of the single stent, which means I distorted my stent whether with the abdominal rewiring or by the interaction of the catheter with the stent. Now, for that, I am not sure that I need any evidence in terms of, randomized trials.
Yeah.
It's a practical, actionable point which you have by using imaging and which you do not have if you do not have imaging, because if you have a resistance to your balloon, if you experience a resistance to your balloon after you place the stent and you don't have no imaging, you have no idea why is that happening.
Yeah.
Is it because of underexpansion? Is it because of abdominal rewiring? Is it because of the distorted stent? And all these three things require different solutions. So actionable imaging means to detect which of the three that I just said is the fact, and then you try to follow up. So do we actually need, randomized data will be important for the guidelines, but moving along and moving forward, just the experience we get from using imaging can really help us to be in a practical way better in performing left main PCI. What's your take on that?
Yes, absolutely, because particularly in the left main, where the guiding catheter is so close to the proximal edge of the stent. And this usually is malapose because by angiography, you always underestimate the size of the stent on the pod balloon. Then it's very common to have malposition. And then the guiding catheter is continuously in and out of the left main. When you are, for example, removing the jail wire or you are removing a balloon, maybe the guiding catheter is crashing the proximal edge of the stent, and you have this deformation. And you're right, it's my advice, for example, always when you rewire one branch after the first stent, please check with IACS. It takes you just a few seconds that the wiring is correct and it's not abluminal, because when it's abluminal, we have the problem. Again, to check the position. If the position is not good, first do a pod again with a larger balloon, and then you prevent the deformations. Then, and finally, when you do the last run of the IACS, the last one, you should always pay attention to the proximal edge of the stent that is okay, perfectly circular, perfectly opposing the orthostal junction, and not with deformation. This is one of the limitations of OCT sometimes, because at this level of the orthostal, you're going to have a lot of blood, and you cannot clear out, then maybe the imaging is not as good. But anyway, it's very important, as you say, you don't need a trial to demonstrate that it's important. In the Excel trial, the deformation of the stent was related with events. In the October again, then it's clear.
Yeah, I think this is a very important point. The distortion of the stent was related to the events in the Excel trial clearly, and in the October trial, it happened in 1/5 of the patients. And without imaging, you most likely will not see it on angio alone. So that's an important message. As we speak about these practical aspects, I would like to remind everyone that you can ask questions on the PCR online platform as we speak, and we'll try to address them all, of course. Now, that being said, you described the October trial and the mandatory 3 runs that you had: pre, after rewiring of the side branch, and post stenting. With the optimal, you described a bit of a different sequence. So would you now say practically that after every rewiring in the left main, you would follow up with the imaging catheter, or only if you feel a resistance? How do you say about this?
Yeah, this is right, that sometimes the wiring is so smooth and you see that the wire is navigating properly and the balloon is without any resistance, that you can be pretty sure that it's okay, no? And then I do not perform this checking of the wire with IACS in every single case, but just in the case that I have some trouble, I feel some friction of the wire, or when you push the balloon and you just feel the minimal crushing, just please do not insist. Do not force, do not push, remove the balloon and check with the IACS. And then that's my advice for this situation.
Okay. That being said, we remain by the practical question of the standardization of the use of IACS and OCT in the left main. Now, I would like everybody to read this paper by you, which was published in Eurointervention in 2020. And this was one of the best papers, in my opinion, in this subject, because it showed that having a predefined protocol for intravascular imaging will be better than using intravascular imaging, but without a protocol, without a plan. So having a plan is always better than not having a plan in interventional cardiology. And you proved this in this beautiful paper, I thought. And one of the things which you said, expansion, apposition, and checking stent edges for black burden or dissections, this is pretty standard knowledge if you use intracoronary imaging in any part of the vascular tree. But already in 2020, you anticipated the importance of stent deformation, and you said that we should actively seek for stent deformation or check for it at the end of the procedure following stent implantation in the left main. How would you comment on this, what I thought was a very important article?
You said a very important thing at the beginning. We need a standardization, and we need checklists in medicine. Not only medicine, go to any aircraft before taking off. We need a standardization of procedures. We need checklists because humans sometimes lose attention. We need to warrant that we do not miss important information. And also we have to set the goals or targets for a good procedure. It's not just to use imaging to say, it looks okay. No, stop, follow a checklist of distal, mid, proximal, and pay attention to the different aspects. Stent edges, distal, proximal, expansion of the stent, a position, etc. It's just to follow an order because humans need this step-wise approach to everything that is somehow complex, not only in medicine, but in life in general. Then the study we conducted is because I was thinking at the time, 5 years ago, that, okay, we have many people doing imaging, even in hospital, but the people is doing imaging in very different ways. And I was doing a more standardized and protocol-based approach for several years. And I decided to compare how were the outcomes in those cases with a very well protocol procedure of IACS guidance and the others. And we found a difference in outcomes. And it's because in the last years, we were using IACS in a more well-informed way of setting the different standards, the checklist at the end of the procedure, and the goals to meet, to seek for the stenting. That's very important in general, in medicine in general.
So if you let me summarize, we, I think, have said or discussed three important things. First, if we advocate intracoronary imaging for left main PCI, we need to be aware of the fact that it's based on observational data, which shows that it reduces mortality, and that we now have a randomized study which has completed its recruitment, and we await the results hopefully in 2025, which randomized 800 patients to IACS-guided left main PCI or angio-guided left main PCI. And this, I think, is an important piece of information for our community. The second point we discussed was the practical benefits of using intracoronary imaging. Away from the evidence, just finding out why you have problems with delivering balloons to the side branch, you use the intracoronary imaging to understand the problem and maybe detect stent distortion and correct it, and it is actually associated with clinical outcomes. So correcting it is a good idea. And then the third point, which was important that we discussed, was the standardization of intracoronary imaging use. With your beautiful paper from 2020, a move towards standardizing. So every time we use IACS in the left main or OCT, we have a sequence of steps that we need to follow, and this could provide benefits. That being said, my question to you is, I have picked up my use of intracoronary imaging for left main PCI to almost all of the cases that I do. However, in the setting of acute coronary syndromes, I'm hesitant to use it many times. What is your take on IACS-guided left main PCI in acute coronary syndromes?
This is a very important question that many, particularly young interventionalists, ask me. What are you doing when you have a patient with a calculate lesion in the left main, acute coronary syndrome, maybe 90%, a typical critical stenosis, TIMI flow 2, and maybe hemodynamically in the borderline. And I say, cannot be assessed with the use of imaging at this baseline moment. At that time, what you have to do is to cross the wire and to open with the balloon to get flow, to restore the flow, to have a more calm situation. Maybe you have to place an impella first. I don't know, because the hemodynamic condition is not good. And then when you are ready to start, please open with the balloon, the lesion, have some flow, restore it, because we do not want the IACS catheter, the OCT catheter, to create ischemia, to induce ischemia. No, we don't want that. You can predilate, then predilatation, you can just use imaging to plan the 1 or 2 stents, there is calcification or not. But sometimes in the acute coronary syndrome, what it do is just the post-stenting imaging, not the baseline, no? And these are important. We have not to be straight and rigid. Sometimes we have to be flexible. And in a patient with a 90% stenosis timid to flow critical condition, I think it's not safe to start doing imaging before just opening the vessel, no? With or without hemodynamic support. Yeah.
Great. Thank you very much. One of the last questions we got, and we have 1 minute to go, was how to perform proximal optimization technique in the left main. Well, I think the best answer is whichever way you perform it, check with the IVUS or OCT at the end whether it was good, because performing POT on a beating heart is not easy, and intracoronary imaging will help you assess those results. Jose Maria, thank you very much. It was great having you, and everybody can watch it on demand on PCR platforms. Thank you once again, and see you again for a heart-to-heart conversation.
Thank you, Dejan.